Hello, everyone. Today's topic is patient-controlled analgesia. Objectives, definition of pain, what is total pain, um, define acute, chronic, and transitional pain, WHO Analgesic Ladder, IV PCA of IV patient-controlled analgesia. We'll give a little, talk about epidural PCA. We'll talk also about opioids, and then we'll give our final remarks here about the topic. Definition of pain. This definition was put forward by the International Association Society of Pain, IASP, in the mid-80s. Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. Total pain is basically physical or non-physical. Physical is like nociceptive inflammatory pain and neuropathic pain. Non-physical, emotional, social, and spiritual. Nociceptive pain is non-neuronal tissue damage. Inflammatory pain is defined as increased sensitivity due to the inflammatory response associated with tissue damage. Neuropathic pain is pain arising as a direct consequence of a lesion or disease affecting the somatosensory system, either central or peripheral. Multiple types of pain again. So what is the difference between acute, transitional, and chronic pain? Acute resolves with healing of the causative injury and has a protective biological function to protect against further injury. Protective reflexes include withdrawal, muscle spasm, and autonomic reactions. While chronic pain is a pain lasting beyond expected recovery period and identifiable pathology, is insufficient to explain the pain state. It disrupts sleep and normal activities of living and doesn't serve as a protective adaptive function. Some authorities like to, specify certain time frame, like 3 months, or 6 months for chronic pain. Transitional pain is focused on treating patients who are at risk of transitioning from acute to chronic pain following surgery to prevent the development of chronic pain and related disability. So transitional pain is somewhere between acute and chronic. And this is why specifying time frames could be somewhat difficult. Okay, it's not a number, it's a condition. Acute postoperative pain guidelines in 2016, the American Pain Society published clinical practice guidelines for post-surgical pain management. And the bottom line for these guidelines is that the evidence-based recommendations supported use a variety of analgesic medications and techniques, as well as non-pharmacological interventions. And also, they recommended proper use of systemic pharmacological therapies, multimodal therapies recommended. This is basically the WHO Analgesic Ladder that was put forward by the WHO in the mid-80s as well. And it was developed early on for chronic cancer pain. Now we have modified this, WHO Analgesic Ladder, so it will include chronic non-cancer pain and also acute pain. Now, with acute pain, it works the opposite. You go down the ladder, while in chronic pain, you go, up the ladder. So this is a huge difference between acute and chronic pain here. For example, if I have a sickler coming to me in the ER, I'm not going to start with giving him some paracetamol. I mean, if he's in a pain crisis, I will start with the big, strong medications here, like morphine, for example. And then as the patients start to get better, we can start to, cut back these, strong opioids. This is a nice picture for multimodal analgesia. Multimodal analgesia works on, the whole pathway of pain, starting from transduction, conduction, transmission, modulation, perception, and CNS responses. The more you adopt this multimodal techniques, the stronger results you will get. It will be more beneficial for the patient. Pain categories. We have acute pain, chronic pain. We have acute on top of chronic pain. We have patients with history of drug abuse, treatment-related pain, and dying patients. Opioid tolerance versus opioid naive. This is a very important topic, guys. And basically, we don't have one definition. We have at least three definitions for opioid tolerance versus opioid naive. And I want you to take a note of this. So the first one is opioid tolerant are the patients taking for 1 week or longer at least 60 milligram of oral morphine per day or its equi-analgesic dose. Opioid naive are the patients who don't meet the above criteria. So this is one definition. You have to take at least 60 milligram oral morphine for 1 week. Simpler definition I found was opioid naive are those that are not chronically receiving opioid analgesics on daily basis. And the opioid tolerant patients are the ones that are receiving opioid analgesics on daily basis. Another simpler definition also is patients opioid naive are the ones that did not receive any opioids in the last 30 days. I mean, you can pick up whichever you want. I do believe myself that the one in the middle will be more reasonable than anything else. And it's straightforward. Okay, I'm going to talk about a couple of, physiological parameters here. The Cmax, which is the maximum or peak serum concentration that a drug achieves in a specific compartment or test area of the body after the drug has been administered and before the administration of the second dose. It is a standard measurement in pharmacokinetics. Cmax is opposite to Cmin, okay, which is the minimum or the trough concentration of the drug achieving after dosing. Short-term drug side effects are most likely to occur because of, reaching the Cmax or near the Cmax, whereas the therapeutic effect of the drug with sustained duration of action usually occurs at concentrations slightly above the Cmin. Another important definition is the half-life, elimination half-life. Elimination half-life is the time taken for an amount of a drug in the body, as well as the plasma concentration, to decline by one half or 50%. Drugs with long half-lives accumulated during repeated administrations. 5 times half-life concentration reach 97% of the steady state. A loading dose is an initial dose given to shorten the time it takes to reach the steady state. This is basically the Cmax, 50% decrease in the concentration, elimination half-life, and this is a comparison between different routes of administration, oral, IM, and IV. As you can see, the oral takes longer time to reach its Cmax, while the IV is almost immediate. You give the drug, you get to the peak. IM takes time in between the oral and the IV. Okay, so why we use what we call patient-controlled analgesia? As you see from these pictures, the peaks and troughs of analgesia that's associated with intramuscular opioids compared to doing an IV PCA. All right, with the PCA, the peaks and troughs are staying within the therapeutic or the analgesic corridor here. So it would definitely give you a better analgesia versus, the PRN approach with IM, for example. Key questions for any consultation in pain management. First, you have to think about it this way. Is this an acute pain, chronic pain, acute or on top of chronic? Is this patient opioid tolerant or opioid naive? What is the nature of the pain? Cancer, lung cancer, treatment related? What's the mechanism of pain? Physical or non-physical? Okay. Does the patient has a history of drug abuse? And also, is this patient is an actively dying patient? PCA advantages. The primary advantage of a PCA is to shorten the interval from patient-defined need and the time of actual analgesic administration. We know from studies that, since the patients, call for a pain medication, it takes around 45 minutes until this patient receives the medication. But if you have the PCA, he can immediately administer the drug to himself. PCA allows for more immediate relief of incidental pain. Okay? And incidental pain is one of the worst types of acute, or breakthrough pain. Because it can happen from just a cough, for example, or a certain movement. Can provide patients with a greater sense of personal control over the pain. PCA reduces the likelihood of overdose by limiting the amount of medications given to the patient. It improves patient satisfaction, especially post-operatively. It reduces the workload by nursing staff. Patient-controlled analgesia is a technique whereby patients can self-administer parenteral analgesics. PCA devices need the following orders: PCA dose, a milligram or microgram. They also call a patient-initiated dose or patient demand dose or bolus dose. Then the delay interval, the lockout in minutes, period during which the patient cannot obtain additional demand medication. Continuous infusion in milligram per hour, microgram per hour, and our limit maximum amount of drug to be dispensed in defined period of time. Most palliative care patients will need both PCA demand and continuous infusion dosing. Opioids used in PCA devices include morphine and fentanyl. IV or sub-Q are the most common routes of administration. PCA can also be used in the epidural space. PCA settings, whether it's a PCA or epidural, patient-controlled epidural analgesia. First is the loading dose. A loading dose is the initial dose given to shorten the time it takes to reach steady state. And it's basically 2 times the bolus. The bolus dose is a patient-initiated dose. Higher concentrations available for palliative patients and double strength for severe acute pain. So when they asked me at King Fahd Medical City to put some protocols for palliative PCAs, of course, what I did is I started from the simple regimens to very highly sophisticated regimens, because palliative care patients probably will need much more than a regular post-operative patient setting. In post-operative, usually we use the simple, traditional regimens, and maybe in difficult cases, you can double the dose in the PCA. Then you have the continuous infusion, not to be given in opioid-naive patients. Take a remark of this. So if you have somebody that's opioid-naive, it's better not to start immediately with continuous infusion, because we found that this can lead to respiratory depression. And generally speaking, continuous infusion is 2 times the bolus. The lockout is somewhere between 5 to 15 minutes and depends on the drug itself. So a short-acting drug like fentanyl will probably have a shorter lockout interval, maybe 6 minutes, for example. Something like morphine, maybe 15 minutes, because it's water soluble. It takes more time than fentanyl to kick in. So, and it takes time to in the blood. So it's better to make it spaced out, and maybe something between like fentanyl and morphine, like hydromorphone, will be something like 10 minutes. There's no exact science about this, but generally speaking, for the sake of making it easy on everyone, I like to use just one number for for all of these opioids. I remember back in King Fahd Medical City, we're using 8 minutes. I think it's reasonable, or 10 minutes also is reasonable to most of the opioids. Okay, 1 hour limit is the maximum amount of drug to be dispensed in a defined period of time. Sometimes, in difficult cases, we just, don't do a 1 hour limit here. If the patient would keep using this, button here. PCA indications. Prime indication for PCA is a patient who requires parenteral analgesia, such as severe pain and or transdermal or rectal routes are not usable. Incidental pain, we talked about this. Pain patterns that are not predictable. PCA is also indicated for use as a method of rapid dose titration. Those findings in acute severe pain. PCA, so sometimes we have these difficult cases, and to really know how much we gonna need, you might want to start with a PCA, which will give you some sort of an idea of the patient needs. Number 6 is PCA is an effective, safe, and well-accepted treatment for post-operative pain, sickle crisis pain, and acute cancer pain. PCA contraindications. PCA is contraindicated in a patient that's unable to understand the concept behind PCA. Allergic reaction to the selected medication. Coagulopathy in the case of patient-controlled epidural analgesia. Relative contraindications, chronic renal failure, sleep apnea, have anticipated analgesic needs less than 24 hours. So it doesn't make sense I put a PCA in a machine, a PCA machine for a patient probably would need less than 1 day use of his opioids here. And I've seen this, unfortunately, done in so many places. I mean, if it's a simple procedure, do not start a PCA. Just use a regular, PRN approach. Dosing. So dosing depends on whether the patient is opioid naive or non-naive patients. So opioid naive patients, okay, you start with, let's say, a standard dose of 1 milligram morphine, delay interval or the lockout 10 minutes, and the total dose is given over 4 hours, is calculated, and hourly rate determined. Let us say the patient used 16 milligrams over 4 hours. Then the patient needs 4 milligrams per hour. So the new PCA demand dose will be calculated as 50% of the hourly continuous infusion rate. So 4 milligrams divided by 2 would be 2 milligrams. And the patient will get a continuous infusion of 4 milligrams per hour. Another thing here that you have to be aware about is non-naive patients. And these folks try to calculate the 24-hour IV dose and divide it by 24 and give the hourly continuous infusion rate. And then you put on it the PCA demand dose initially calculated as 50% of the hourly rate. So this is one technique, okay? Now, I want to say that in post-operative patients, we do not use continuous infusion because most of the time these patients are opioid naive. So we use only, PCA boluses, okay? Now, this is not the same token like a patient that's a sickler that are taking opioids at home. Then this patient will calculate the amount of opioids he's taking, will do it in 24 hours, and then will divide the hourly rate by 2. This will give you the PCA demand dose. So what I'm trying to say is each condition is different, okay? Most commonly used medications, of course, opioids are on the top of the list here. Then local anesthetics in epidurals, clonidine in epidurals, NMD antagonists. You can add ketamine. You can add ketorolac. You can add also antiemetics like ondansetron. Different types of machines for PCA. I like, I mean, personally speaking, the portable ones, the easy to uh, walk with, because the whole idea is I want the patient to ambulate. So the one in the middle, for me, I don't know the brand, I don't care, but uh, I want to say that this is, something that I can walk with. Okay, the other machines are pretty heavy. I mean, you cannot walk with these machines. So that's my point of view. Whether you use it for an epidural or an IV PCA. We have disposable also, PCAs. We use them a lot in Egypt. I'm not gonna get into the details of it, but it works very well, to be honest with you, especially in the post-operative period. I use them even in, palliative setting as well. We send the patients on these disposable PCAs at home. Patient-controlled epidural analgesia. High-quality analgesia than IV PCA, especially in thoracoabdominal surgeries, because it reduces the incidence of atelectasis, ileus, and thromboembolic complications. So we love doing epidurals in thoracoabdominal surgeries in particular, okay, because of these three reasons or complications: the atelectasis, the ileus, and thromboembolic complications. And usually we use a mix of local anesthetic and opioids. The local anesthetic takes care of the somatic pain, while the opioids takes care of the visceral pain. Of course, this one requires more careful monitoring, as local anesthetics can cause hypotension, while opioids can cause respiratory depression. Patient-controlled epidural analgesia. Opioids. We're going to give you a little nice talk here about opioids. First, you have to know the chemistry. We have morphine-like medications. We call them the phenanthrines. We have benzomorphines. We have, uh, phenylpipridines, diphenyl, heptans, phenylpropylamines, or these are like tramadol and all that stuff. As far as PCA goes, we're not gonna talk except about these three categories here: the phenanthrines, the phenylpipridines, and the phenylpropylamines. The mechanism of action of opioids. I mean, I'm not gonna ask you to go very deep, but you should know how opioids work, because this is something that you'll be using, in your everyday. So first, it goes into 6 steps here: attaching to the G receptor complex, activate G protein, inhibit adenylate cyclase, decrease in the cyclic EMP, reduce intracellular calcium, and increase potassium efflux. This is basically the 7-transmembrane G protein. It allows potassium go out, prevents calcium from getting in. That's the bottom line. Okay? Opioid receptors. This is also important. We have mainly, the mu, the delta, kappa, nociceptin, and zeta. Sigma is not an opioid receptor. Okay? And this one is stimulated by a drug like ketamine, for example. Nowadays, it's not considered an opioid receptor. So take it off the list. But I had to add it so it gives you some sort of awareness where we are right now. The mu receptors are the most important ones. It gives you the analgesia, physical dependence, euphoria, meiosis, hypoventilation, urinary retention, pruritus, nausea and ileus. Kappa is analgesia, sedation, and dysphoria. The delta modulates the mu receptor, and nociceptin is related to tolerance, and zeta is related to the regulation of cancer cell proliferation. These things are still under research. We have different groups of drugs. We have pure agonists, partial agonists like buprenorphine. We have pure agonists, which include most of the, most of the opioids. We have a new drug called Remich or nalfurafine. It's a kappa agonist, pure kappa agonist. Then we have the nalbuphine, which is an agonist antagonist, and pentazocine. And then we have the antagonists like naloxone, naltrexone. And then we have here peripherally acting mu opioid receptor antagonists. We call them the pamoras, like Relistor. I mean, the difference between an antagonist and a pamora is the pamoras are not able to cross the blood-brain barrier. So they treat the side effects of opioids without reversing analgesia. This new drug from Japan is used in itching, pruritus, related to chronic kidney disease. Okay, opioid intrinsic activity here. As you can see, partial agonist, buprenorphine. If you get in the exam, what is the only partial agonist? A mu agonist, partial mu agonist. It's buprenorphine. As you see with these partial agonists, you get some ceiling effects. For respiratory depression and sedation. So somewhat it's safer than the full agonist. But still, you can get respiratory depression. I don't want you to misunderstand me here. You still can get respiratory depression from buprenorphine. Drug metabolism. As you know, it goes through two phases, phase 1 and 2. Phase 1 includes basically the P450 system, while phase 2 is basically conjugation. And then after being metabolized in the liver, it goes and gets excreted in the kidneys. These are the different P450 enzymes. You have to learn this, guys, because it has an important role in understanding, the side effects of these medications. The commonest CYP450 is the 3A4. It accounts for 36% of the P450 enzymes, while the 2D6 is next to it is 19%. And then 1A2 is 11%. And then the rest of these, P450, enzymes. So drugs that are metabolized by the 3A4 are fentanyl, methadone, buprenorphine, alfenta, and most of these drugs, they give inactive metabolites after being metabolized with the 3A4. These are the inhibitors and these are the inducers. So the key understanding for this is, if let us say I gave you a macrolide, like for example erythromycin, okay, and I use fentanyl patch. Basically, I will inhibit the metabolism of the fentanyl, which goes to inactive metabolites. So this can lead to overdose from fentanyl. And I want to tell you, I had 2 cases in my clinical practice that had such a combination. Patient received erythromycin, he was on the patch. Patient came to our clinic, overdosed, and we took care of it. Of course, we took out the patch, and the patient did well. Okay. How about inducers? So I've seen this also a few times. Patient is on Tegretol, carbamazepine, and the patient then receives fentanyl, for example. The drug doesn't work because it uh, induced the enzyme that metabolizing the drug, so it ended that you're having inactive metabolites. So you have to go up on the patch, okay, or the whatever IV form or whatever. And then we have the 2D6. This is opposite to the 3A4. The metabolites are active, are more potent than the parent drug. So you just have to flip things here. So, for example, patient is on oxycodone, getting SSRIs. Okay, so this will inhibit its metabolism, and thus it will, you will have less potent metabolites. So it will weaken the drug itself. Conjugation. We see this with some drugs like morphine, hydromorphone, or even nalbuphine or naloxone, levodopa, tapentadol. Usually, these metabolites accumulate in renal diseases. So, the nice thing about drugs that metabolize by conjugation is we have minimal or no drug interactions. Opioid metabolites. Morphine is metabolized to M6G and M3G. M6G is analgesic. M3G is excitatory. Okay, the M3G is the commonest metabolite, more than 50%, while M6G is 10%. When you have a patient on morphine and develops renal failure, for example, and then he will start to accumulate the metabolites, he will get a mixed delirium. Why? Because we have M6G and M3G. So you go and see the patient. Patient is comatose, but having myoclonus, having both, sedation type of toxicity and excitatory toxicity in the form of myoclonus, in the same time. Hydromorphone usually metabolite is the excitatory one, the 3-glucuronide. But it's still much safer than morphine in renal failure patients. The ones IV opioids used for PCAs, tramadol, meperidine, and nalbuphine. Morphine. Morphine is the parent of these drugs, oxycodone, hydromorphone, and fentanyl. Now, I want to give you just a little hint here. Meperidine can be used only for 48 hours in acute pain setting with a normal renal function and not more than 10 milligram per kilo per day. The reason is meperidine can accumulate a metabolite called normeperidine that can cause, seizures. I've seen it 2 times also in my clinical practice. And this was after a cesarean section. Patient lost a lot of blood, had pre-renal, azotemia, was put on a PCA meperidine. We used to do this meperidine a lot in old days, and I think a lot of people still do it. And then the patient develops seizures. Okay, I'm going to give you some questions here. So this is a 70 kilo, 60-year-old man with hypertension and chronic renal failure, unresponsive, found unresponsive and apneic. 2 days ago, he began administration of a PCA morphine with a continuous rate of 1 milligram per hour with a dose of 2 milligram and lockout interval of 10 minutes. The dose of morphine totaled 60 milligram over 48 hours. Which of the following is the most cause of the patient condition. So again, it's the accumulation of M6G because it's the analgesic and the sedative metabolite, more potent than the original morphine itself. Okay, I just put this picture to give you an idea about the opioid-induced neurotoxicity in general. It's a spectrum. Okay, it starts from tolerance, ends with seizures. All right. In between these spectrum, you can develop delirium. You can develop opioid-induced hyperalgesia. I think this picture is so beautiful and representative to the opioid-induced neurotoxicity. And as you can see, also you can see in the middle the myoclonus, mild and severe, and so forth. Oxycodone. All statements below as regards oxycodone are true except it belongs to phenylpiperidine. No, this is wrong. Oxycodone is related to morphine. It's under the phenanthrene group. And this has an important implication, guys, because, let us say you're allergic to morphine. Then there's a probability that you'll be allergic to oxycodone as well, because you are in the same chemical group. And thus, you might need to shift to another chemical group, or you have to test the patient for allergic reaction before you administer the oxycodone. Okay. There are reports of lethargy and ventilatory depression in dialysis patients. Yes, that's true with oxycodone. That's why I prefer hydromorphone than oxycodone in dialysis patients. I want to say something. There's no drug that's completely safe. It's safer. So hydromorphone is safer than oxycodone. But if you give it in excess, you will get opioid neurotoxicity. It's metabolized in the liver, and the drug depends on the kidney for excretion of active metabolites. That's correct. It's a semi-synthetic opioid with twice the analgesic potency of morphine, and that's correct. Semi-synthetic means that it's derived from morphine, chemically derived from morphine. Okay, synthetic drug that has nothing to do with the parent drugs, like morphine. For example, methadone is a true synthetic drug. Okay. Hydromorphone. Which statement is not true regarding hydromorphone? It has the same potency as morphine. That's the answer here, because it's 5 times as potent as morphine. Hydromorphone is metabolized to 3-glucuronide. That's correct. Patients with renal impairment in palliative care unit had an improved side effect profile when switched from morphine to hydromorphone. Yes, this is correct. And the metabolite is excreted in the urine and accumulates in renal failure. Again, it's safer than other opioids, but you have to cut down the dose in renal failure patients and also make it less frequent. Nalbuphine. We utilize this medication a lot in Egypt. Which of the following statements are true as regarding nalbuphine? It's used as a solo opioid to treat opioid side effects such as and to treat opioid side effects such as itching, urinary retention, constipation, but not respiratory depression. This is correct. So naloxone or nalbuphine is not used like naloxone to treat respiratory depression. This is very important. But you can treat other side effects, such as itching, urinary retention, constipation. It's an agonist on kappa, antagonist on mu. Yes, it's an agonist antagonist. Conversion is 1-to-1 ratio with morphine. Dual metabolism via glucuronidation 75% and P450 25%. All of the above statements are correct about nalbuphine. Fentanyl. A 47-year-old man requires analgesia in the ICU, and this patient developed hepatorenal syndrome. Once you hear this word hepatorenal, your first choice goes to fentanyl. Meperidine, which of the following conditions is most likely to result from prolonged use of high doses of meperidine, especially in patients with renal failure? Seizures. Again, meperidine can be used in acute pain only for 48 hours, okay? But you have only one contraindication is, kidney failure, chronic kidney failure, all right? The obstetricians love meperidine for postoperative pain relief, and they use it up to now. Okay, so be careful about this. So you really need to learn about meperidine, and also patients love it. Okay, a very addictive drug. Especially like in sicklers, like in old days, we used to use meperidine in the ER all the time. Meperidine was the drug of choice. Of course, it's a catastrophe if you. The patients will keep coming to get this medication. So be careful about meperidine. Try to avoid it in general. It has some advantages. Okay, there's no doubt about it. It's good also for shivering. If you have a shivering patient, give him a 25 milligram dose of meperidine, and this will get rid of it. Tramadol. With tramadol, here a case, 32-year-old woman referred to the pain clinic receiving analgesic therapy for chronic intractable low back pain. She has a 15-year history of major depressive disorder, in remission for which she receives phenelzine, an old MAO inhibitor. Which of the following medications is most likely to cause serotonergic syndrome? It's tramadol. Why? Because tramadol, inhibits the reuptake of norepinephrine and serotonin, and it has a dual action, inhibiting the reuptake of the catecholamines, the norepinephrine and serotonin. Also, it's a mu agonist. Okay, so that's why it interacts with MAO inhibitors, and it can cause serotonergic syndrome. Generally speaking, I've used tramadol post-operatively, and I want to tell you it's a weak drug, causes constipation, has a lot of side effects. It's not my favorable medication. Yes, tramadol is good in non-cancer pain, for simple, pain problems. Okay, mild to moderate pain issues. That's my main use, but it comes in IV form, and patients, people still using it. Okay, and they can put, and people use it in PCAs. So I just wanted to give you an idea about it. I'm not a big on tramadol IV. Just the oral tramadol is good, unless you don't have other available opioids in your possession here to give to the patient. Okay, top side effects of opioids. We talked about it in our presentation, opioids and opiates. Okay, perioditis. By the way, opioids is the semi-synthetic and synthetic drugs. Opiates are the natural ones, and basically there are two of them: the morphine and codeine. These are the natural opiates. Okay, just for terminology purposes here. So these are the side effects of opioids. We're going to talk about some of them in this presentation, and I've talked about them in my other opioids and opiates presentation. Please look it up. So first one here, question: which of the following opioids does not cause meiosis? Meperidine. Okay, because meperidine has an anticholinergic side effects, and thus it dilates the pupil instead of constricting. Allergy and pseudo-allergy are, or sometimes they call it anaphylaxis, uh, you know, and pseudo-allergy, anaphylaxis and anaphylactoid allergy and pseudo-allergy. You will hear these two terminologies, and basically the same. But generally speaking, pseudo-allergy is related to idiosyncratic release of histamine, while allergy or anaphylaxis is a true hypersensitivity reaction related to the production of excess amounts of IgE. Okay, so usually with anaphylaxis, you got to have a previous exposure before you get the allergic reaction. It doesn't happen from the first time. But with pseudo-allergy or anaphylactoid reaction, it can happen from the first time. And usually the allergic reactions is more severe, and it comes with angioedema of the and lip swelling. Okay, so if you see lip swelling, this is probably a true allergic reaction. Otherwise, sometimes it's very difficult to make a distinction between the two. Okay, so this is for a true allergic reaction. And of course, in this situation, you have to give epinephrine. I am epinephrine. Okay, nausea and vomiting. I wanted just to show you that, there are different mechanisms for nausea and vomiting. The important here lesson, that drugs usually cause nausea and vomiting by stimulating the chemoreceptor trigger zone. And opioids are not an exception. So this is basically the question here. Which statements below is not true regarding opioid-induced nausea? It's mainly mediated through the cholinergic pathway. No, the main pathway is chemoreceptor triggers. Most nausea and vomiting resolves in 2 to 3 days, and this is correct. Okay, so decreasing the dose of the opioids may be enough to relieve the symptoms, but if you cannot really get rid of the nausea from the opioids, you have to do opioid rotation. Opioid-induced constipation. This is another common problem that we see with opioids, more so with oral opioids than IV opioids, but all opioids can cause constipation. And usually the treatment for opioid-induced constipation is the regular, laxatives that we know about, the Senna and Lucosade, but we can also give something like Pamoras, okay, that can reverse the constipation without, reversing the analgesia. Constipation. So treated with Senna, Bisacudo, Lucosade, lactulose, and then methylnaltrexone or Relistor, which is basically, we call it a Pamora, or peripherally acting mu opioid receptor antagonist. Remember this name, Pamoras. Basically, there are two of them, methylnaltrexone, and there's an oral one called naloxone or Moventic. Opioid-induced itching. Which statements regarding opioid-induced are true regarding opioid-induced pruritus? It occurs in 90% receiving new axial opioid. This is true. So the itching, I see it mostly in patients that receiving epidural, analgesia. There's evidence that using agonists-antagonists can reduce the pruritus without compromising analgesic effect. This is true. As we mentioned before, nalorphine, one of the indications of nalorphine or nalbuphine is to treat the side effects of opioids, except respiratory depression. Respiratory depression, you have to give naloxone. You have only one choice here. Ondansetron has been shown to be useful in opioid-induced itching. So this is also correct. And I want to mention something. On ondansetron, there have been a lot of research on it and pruritus. At the beginning, they had some success, and then later on, it turned to be that ondansetron really is not really a very effective medication for pruritus. Despite it's an anti-serotonergic drug, and we know that serotonin is implicated in pruritus. But they found that ondansetron is useful in opioid-induced itching through the neuroaxial nerve. Like a patient receiving an epidural, for example, and you're giving him, a mix of local and opioids started to itch. I mean, antihistaminics will not do much. Okay, this one will be more efficient. Antihistaminics would be good for somebody receiving IV morphine because IV morphine can release histamine peripherally, and thus giving diphenhydramine, for example, is a good idea, right? But for the neuroaxial itching, it's better to use either ondansetron or nalbuphine. I hope this is clear, so. And these are the drugs for, so these are the ones for itching, and this one ones for nausea and vomiting. Of course, ondansetron and granisterone are standard drugs in nausea and vomiting related to opioids, and also metoclopramide. The only contraindication for metoclopramide is intestinal obstruction or a patient with Parkinson's. Urinary retention. Common causes of urinary retention in hospitalized patients are opioids, constipation. Use of bladder scanning has reduced the incidence of urinary tract infections, and at last year, all of the. So opioids induce constipation. Constipation will induce urinary retention, and it's a vicious cycle. Okay, guys? I'm telling you this. This is a very important slide. I remember when I was covering the acute pain, they will call me regarding patient is not receiving adequate analgesia post-operatively. Patient is hurting like hell and all that stuff. So I used to go and see the patient by myself, okay, or send somebody from the fellows or whatever. And I asked them, to see the patient. Okay, the reason is sometimes the patient is not hurting because of the incisional side. He's hurting because of urinary retention or because of constipation. And if you give him more opioids, you're going to make it worse. Okay, so you need to eyeball the patient and ask him where is his pain is. And if it's in the urinary bladder area or bowel, okay, now you know the problem. Then you work on it. Putting a Foley, maybe, as far as the constipation, you give anti-constipation agents. Also, you can, for a urinary retention, you can give like a Pamora, you can give a methylnaltrexone, okay? But don't give more opioids. You make it worse. Respiratory depression. So first of all, you have to define respiratory depression. Respiratory depression is defined by respiratory rate less than 8 per minute for adults and 10 per minute for patients like 8 to 12 years old. And basically, we dilute the naloxone, which is 0.4 milligram in 10 cc, and give it very slowly. Be super careful, guys, because I want to say that if you give it as a bolus one time, you can cause acute pulmonary edema because you will just aggravate the sympathetic system in your body, and this can lead to pulmonary edema. So do it slowly and observe the patient. And then after you finish with your naloxone, you give him a drip of infusion of naloxone, because the naloxone duration will end. The patient will get back the respiratory depression. And sometimes I give one IV and one IM, because the IM can stay longer in your body. Key learning point: patient-controlled analgesia is a technique whereby patient can self-administer parenteral analgesics. Primary advantage is to shorten the interval from patient-defined need to the time of actual analgesic administration. PCA is effective, safe, and well-accepted treatment for post-operative pain, sickle cell crisis pain, and cancer pain. PCA allows for more immediate relief of incidental breakthrough pain, can provide patients with a greater sense of personal control over the pain. Thank you.